Hello, everyone. Welcome to the December monthly training. This month, we're going to be reviewing our airway anatomy and the relevant skills with it. For those in SOCO, this is going to go alongside a hands-on skills lab for the first 3 weeks of December. Your FTOs will hopefully nail down one day for you as a shift to walk through all of our airway mannequins and just kind of touch up on all the skills that we don't get to use all the time. You go to your FTOs for that. But we're going to walk through our airway anatomy, talk about some gas exchange um, at the cellular level, and then go into our skills and some further anatomy for innovation. But let's start here with our kind of general airway anatomy. So our upper airway, this is going to begin at the nose and the mouth. So we're going to come in either through our nasopharynx or oropharynx, and it's all going to funnel into our pharynx. And then we are going to separate from the esophagus into our larynx. Be careful with between upper and lower airway. We're going to call our lower airway at the inferior portion of our larynx. And just a kind of reminder for the quiz questions, because a lot of this information is review and straightforward. We have a lot of those select multiple questions. Um, they're clearly stated in the question, but those get missed a lot because people forget to read the select multiple. This is your fair warning here, as that's going to be a big hitter pretty early on. So remember, go through the mouth, nose, into the pharynx, down into the larynx, where our vocal cords are. And we begin our lower airway. Um, the lower airway is going to begin at our trachea, and it's going to come down into our bronchi. So we have our right and left main stem or mainstream, and that's going to separate into kind of our smaller bronchi, into bronchioles, and into our alveolar ducts and sacs. So we're going to bring in all of our oxygen, all of our air here, and our bronchioles. This is where we're going to kind of humidify the air, filter out any nastiness, and get ready to exchange with our red blood cells to transport it around the body. So gas exchange. Here we have a alveolar duct with all of its sacs, and our capillaries that kind of line up. And this yellow, what it calls a basement substance in here, this is kind of our respiratory membrane. So we're going to breathe in air and it's going to diffuse through our alveoli into the capillaries. This is where our red blood cells are going to drop off the CO2 for that to be exhaled, and the O2 is going to diffuse across and be picked up by our red blood cells, oxygenating them for them to get returned to the system to give all of our organs and tissues the oxygen and nutrients it needs to function. So we have three factors, and this is going to be um, something worth noting for the quiz. We have three factors that are going to affect gas exchange when we're talking about our membrane. So remember that gases, they don't have like an active process to exchange. They want to go from the highest pressure to the lowest pressure. They want no resistance as they're going through one membrane to another. So when there's a bunch of oxygen here and none over here, it diffuses easily. Same with our CO2, it's going to diffuse to the lower concentration on the other side. But this membrane is going to kind of make this more difficult or easier depending on some conditions. So to start, if you ever heard of altitude sickness, that's going to be talking about our magnitude of partial pressure. So this is a gradient that allows the oxygen and CO2 to diffuse. So if the partial pressure of the environment surrounding the person in the atmosphere is different, that's going to mess with this gradient. And again, that altitude sickness is really the biggest one. That's going to make it harder for diffusion to occur. Um, so that magnitude of partial pressure is going to be one factor that can affect gas exchange. The next one is going to be thickness of our respiratory membrane. So if you're thinking about um, basically the amount of space this has to go through to diffuse into the alveoli or back into the capillary, two thing or two conditions can kind of cause the space to increase, and that's going to be pulmonary edema and pneumonia. So, any fluid that can fill up this sac and basically create more distance between the alveoli and the capillaries is going to make it harder for the oxygen to fuse. It's going to slow it down, and it's also going to make it have to go a further distance to make it back into the lungs or back to the capillaries to the red blood cells. So that's going to be our thickness of the respiratory membrane, our pneumonia, and our pulmonary edema affecting gas exchange. The last condition I wanted to talk about when we're talking about this respiratory membrane is going to be the alveolar surface availability. So if we think about our emphysema patients or COPDers where the alveoli is collapsed or just damaged in general, that is not going to allow it to exchange oxygen very efficiently. Again, that can create more separation in this membrane, um, or the structure that it's supposed to diffuse through, or is damaged. So, like physically, there is further obstruction for that oxygen to diffuse. So going back to this, gas exchange can be affected in three different ways when we're talking about this respiratory membrane between the alveolar ducts and sacs and the blood capillaries. That's going to be our magnitude of partial pressure, with the different altitudes being the best example of that, but there's a few other scenarios there we're not going to get into. Our thickness of the respiratory membrane, referring to pneumonia and pulmonary edema, so our fluids that can impact our airways, and then our alveolar surface availability, uh, kind of talking about those pathologies that destroy the alveoli itself. Let's go over some airway landmarks for intubation. Um, Remember, if we're using a Mac blade, this follicular space that's right above the epiglottis, that is what we're aiming for. So we're gonna get our Mac blade, we're gonna sweep the tongue to the left, get into this follicular space and lift, and that's gonna lift the epiglottis, exposing our cords. While if we're using a Miller blade, we're gonna go right for that epiglottis and lift right on it, and that's gonna expose our cords. So there's a lot of different terms on this. Don't get too bogged down by it. The big ones that we want to remember is we have our follicula, our epiglottis. This they call it a fold and cartilage here. This is a pretty good indicator that you're in the right spot. Then obviously we have our false chords and our true vocal cords, and this is where we're aiming for. So again, looking for this cartilage, this V-shaped cartilage here, the false chords, the true chords, for us to be in the trachea. The next slide is going to be a picture from one of our live innovations that we had in the field. Um, so it's a little nasty. The airway isn't the cleanest, just a heads up, but probably nothing you haven't seen before. So it is a little blurry. Again, camera probably got fogged a little bit. It was a hot day and there was some junk in the airway. So apologies for that. But nevertheless, we can look at a few good structures that we just talked about on our last slide. We have our true chords right here that lead us into the trachea. We have our false chords here and here. And this is our V-shaped cartilage that kind of brings us to everything. So we're not seeing the epiglottis here. I'm not exactly sure if we used a Miller or a Mac blade on this innovation, where it looks like the epiglottis is lifted. Maybe it was a Miller, but I know a lot of people have been using the Macs when we use the VLs, so not sure, but that's why we're not seeing anything above. So that's just kind of a good example to look at some airway anatomy kind of in real life. It's not always what the textbook looks like, but that's a pretty good view despite the blurriness, and it looks like we have a little leaf over there. So let's get into our airway skills. The big thing that we get taught is BLS before ALS, and that is very true. If we have someone who isn't oxygenating well, we're not just going to immediately crank them or intubate them. We're going to work through our algorithm, which we'll kind of go through that protocol as we get to the end of this presentation. Um, so for our BLS airway maneuvers, we're going to start with our head tilt chin lift. Exactly what the name says. Remember, just kind of tilting that head back and lifting the chin up. And this is going to help move our tongue out of the way. Remembering that the tongue is the number one airway obstruction. It's definitely in unconscious patients. Um, and because we are kind of cranking on their head here to open the airway, we are not using this in our trauma patients when we want to be mindful of our C-spine. Um, that's where we come over to the jaw thrust maneuver. So here we're going to use two or three fingers on both sides, and we're going to lift the mandible up and out. This is going to allow us to maintain a neutral C-spine. We can do it if they're collared or not. Um, so that's going to be our preference in trauma patients. OPAs, so unconscious person with no gag reflex. Obviously, when we're sticking something like this down someone's mouth, we don't want that gag reflex to be present because we can cause them to vomit, and that is just going to make our day that much worse. Uh, we're going to size this from the corner of the mouth to the angle of the jaw. And when we say we're going to insert with the concave side up, we talk about this side that's kind of right here. We're going to point that to the roof of the mouth, and as we glide over the tongue, we flip it. And this is going to prevent our tongue from flopping backwards. Remember just in pediatrics that we are gonna put this concave side on the side of their mouth and then flip as we glide over the tongue. Again, tongue, number one common airway obstruction in unconscious patients. NPAs. So we could use this on a conscious, semi, or unconscious patient. They can have a gag reflex. If they're awake, this might just be a little uncomfortable. This is good in those who have upper airway obstructions. Let's just go back quite a few slides. You can see how we enter the nasal pharynx. If we're obstructed anywhere here, um, this is going to give us a direct pathway down into the pharynx or the larynx to oxygenate. Or if they just need a little assistance because we're not oxygenating well, this is going to just establish a clearer line to breathe or give them oxygen through. Um, Especially if our we're jaws locked or something like that, the mouth is difficult to open. Um, this is going to be a good option. The last few times I personally have uh, had an MPA placed on calls has been in like seizure patients where they're post-ictal and unresponsive, but they're kind of blue because they weren't breathing very well and their jaws still locked even with some midazolam. The MPA is going to help us kind of bypass that issue. It's not going to improve our seal, but it gives us a definitive path through as long as there's no obstruction further down the airway. So um, need to be a little cautious with the saying definitive in this case. Remember that this is going to be contraindicated in like severe, better to say facial than head trauma. If we have any significant trauma to the head or face, in that anatomy as we move up it can be damaged. We don't want this going someplace it's not supposed to. Unlike the OPA, we don't really see this through. We just kind of pop it in and just kind of trust it's in the right spot. So if there's any damage to the anatomy, basically up in their face where we can't see, this has a potential to cause more harm than good. That's a bad day for everybody involved. Remember these, we're gonna size from the tip of the nose to the angle of the jaw or earlobe. Um, and we're gonna insert this bevel end face in the septum. And we're gonna follow the natural path of the airway. And just remember to loop these up. Eye gel, this is gonna be the blind insertion airway device that we talk about and when they refer to in protocols, we're gonna be talking about the eye gel. So this is gonna be an apneic patient with no gag reflex. Most of the time, but obviously if there's no gag reflex and you need a definitive airway, um, you can start to go through this. But most of the time we're placing an eye gel. These patients are apneic. Uh, Helpful in difficult intubations if we have some unfavorable airway anatomy, or just um, a shorter or longer neck. Uh, the patient is obese. really any factor that is going to make it hard for us to get a good sight of the chords and have a successful innovation, or you're resource stricken, you're the only paramedic on a code, um, then the eye gel is a really good option. There's a lot of studies saying it's very successful. It's almost as good as innovation. Um, Obviously not the gold standard at the paramedic level, but it does a really great job of helping us get an airway. Remember that these are going to be sized based on weight. I think a lot of us probably used the Kings before the eye gels came into popularity. And those Kings, I believe, were based on height. So remember that these eye gels are based on weight. Uh, Remember to lubricate these. Basically, best way to do this is just gonna place it into the airway until you meet some resistance, and then you're gonna pull back just a smidge, and you're gonna be in the right spot. And remember, with any advanced airway, we're gonna be confirming this with capnography. That is our gold standard. Innovation. Again, apneic, no gag reflex, and we need a definitive airway. Again, doesn't necessarily have to be apneic, but can't have a gag reflex. So we're gonna visualize our landmarks that we kind of talked about earlier in this video. And we're gonna visualize the cords, pass the tube through the cords, use our 10 ml syringe to inflate the balloon, um, and secure it with our commercial securing device, our tube tamer. Um, Again, gold standard for confirmation of innovation is end-tidal CO2. Pairing that with our visible chest rise and fall, um, misting in the tube and auscultation, and make sure we're not hearing anything in the stomach. Tube size, adult females, 6.5 to 7.5. Males, more maybe 7.5 to 8.5. When we get to pediatrics, it's going to be their age divided by 4 plus 4. Um, but I'm pretty sure the Broselow tape also provides you kind of a range of references on what tubes to use. For adult size tubes, Um, if we do need to suction them after we place, we are going to use most commonly a 12 French suction unless we have a very large tube. I think above 8.5, you can use a 14 French. But um, for those who have not used a French suction or are not familiar, when we have our suction tube in with the yank hour tip, we remove the yank hour tip. Um, and we have the French suction. I believe the 12 is going to be a white color. Um, Almost that has changed, but it has the whistle tip end. You're gonna place that into the suction tubing. You have that hole that you can cover with your gloved finger, and as you're ready to suction, that is what you cover. Um, do not try to hook up the French suction to the yank hour tubing. Make sure you go right to the suction tubing. I'm going to talk through this slide, but there is a YouTube video linked in the presenter notes. It's from Dr. Ducanto, who really invented this technique. He does a really good job explaining. So that is my um, that is my recommendation to go watch that. But I'll talk through this real quick. So our salad technique is our suction assisted laryngoscopy airway decontamination. So we're going to begin with our suction, our Yankauer suction, clearing the airway and parking it on the left side of the esophagus. From there, we're going to insert our laryngoscope, again, sweeping that tongue off to the left, kind of in the same spot to where that suction catheter is. And we're going to continuously suction as we are visualizing our landmarks. Once we find it, we're going to follow our regular intubation procedure, passing through the vocal cords, confirm with auscultation, and end tidal CO2. Um, these are great in crash airways, um, or anything that has a lot of vomit in it, blood, anything like that. So again, I would go watch that video. It's in the presenter notes, which um, if you have this in presentation mode, then you're going to have to exit out and scroll down and you'll be able to see it. We're going to go through a few protocols here, ones that I found I think were a lot more relevant than some of the other ones to kind of some of the stuff we talked about today. First is going to be our Blue 2. This is our airway algorithm. Be careful. We're going off of the 2025 protocols now, as it is December 1st when this comes out. I believe that Bluetooth is an airway algorithm in the old protocols. So this kind of got moved, unless if I read this incorrectly, which there definitely is a chance. But this is our airway algorithm, puts the big emphasis on uh, BLS before ALS. So respiratory rate, effort adequacy, sorry, and pulse oximetry, and from there, AMT paramedic level, we can use some CAPNO if we have any issues with this. If it's inadequate, we're gonna first start by opening an airway with the head tilt chin lift or draw thrust, suction as we need, and bag. From there, if that's not successful, um, we're gonna move towards our blind insertion airway device or intubation. Um, Successful, we need to place capnography, confirm it. Um, Gastric tube, which is something that we don't really do a whole lot, is something that I wish we included into this. Um, And remember, if we have an obstruction, we can follow the airway obstruction procedures, the Heimlich maneuver. If they're unresponsive, we're gonna use the video or use the laryngoscope and our McGills to try and fish out whatever's there. Um, so yeah, that's our airway algorithm. Really just talks about going BLS to ALS. Some good pearls though at the bottom of this. Continuous capnography being mandatory for all biad or endotracheal tube placed, or if you have prolonged use of a BVM, you can consider the use of capnography. I don't think we've ever run into an issue with people not placing capno on our iGels or ET tubes, but that is, again, the gold standard to confirm that we're in the right spot. Um, I like this part of how, our goal in airway management is to have adequate oxygenation, ventilation, and airway protection. So if we're getting the job done with an OPA and NPAs, we don't have to move to the next step, especially if this is going to be very call dependent. If you have like an overdose patient who, um, like Narcan is going to wake them up, obviously we don't want to be trying to intubate them. But if we have a trauma patient who has an airway that's about to crash, then obviously we're going to want to move towards intubation. So, kind of, I don't want to say common sense, but um, the situation will call for when you need to move up to the next step, or if we're okay with staying where we're at. Um, for our intubation attempts, a lot of times we're intubating that is in cardiac arrest. But if the patient is not in cardiac arrest, if we're bagging them, we're getting ready, and we're not getting a good SpO2, um, you can also put on a nasal cannula with some high flow O2 through it. Um, Also something that we can do in a patient in cardiac arrest, but they make that pearl separate. This is really a lot more relevant in like RSI in patients. Didn't mean to move on. Gastric tube, we can connect it to low suction, has to be very low. Again, something that's very underutilized. And I think that is the big points of the pearls for this. Remember to use the end-tidal CO2 to guide your ventilation. If you have someone who has it really bad before, telling them to create the boxes on the monitor, if you're able to get the waveform up, is usually pretty helpful. Um, yeah. So blue one is going to be kind of our intubation prep list. So airway adjuncts ready. If we're getting ready to intubate the patient, we should start by throwing in an OPA or two NPAs and oxygenating them prior to um, have the nasal cannula in there for apneic oxygenation. Remember, we're trying to kind of wash out all that dead space in the lungs and get as much oxygen available. It gives us a little more time on our intubation attempt. Make sure we have our equipment ready. So you don't want to see if the light is functioning on that laryngoscope until you put it into the patient's mouth. Check it beforehand. Make sure you have a backup blade. Um, have the ET2 ready with the lube, a bougie, syringe, uh, or if you have the stylet, whatever your preference is. Place your tube tamer prior to starting the intubation so you have it ready to go when you do get the tube. And again, the end-tidal CO2, make sure it's ready. Uh, Backup equipment. If you don't get this tube and maybe you see that the anatomy is really hard to navigate when you get down there and you don't really want to try a second attempt, or maybe your attempt was a little prolonged, have the iGel or King, whatever, ready to go in its place. Um, Surgical airway device. This may be more for like if you have an anaphylactic patient that you're trying to intubate. Um, or a trauma patient where the airway's crashing and you're not able to keep up. Those would be like the two big ones where the surgical airway um, would be a good piece of backup equipment to be ready. Um, Make sure your team's ready. Discuss it. Uh, you have someone on the BVM, you have someone getting the equipment ready, somebody ready to assist you. Just make sure you're talking through your plan and you're ready to go. Is your patient ready? Have you been pre-oxygenating? Do you have IV access? Have you looked to see if their airway is going to be difficult, if they have dentures in place? Have we positioned the patient properly? Maybe throwing a towel under their back shoulders to get that ear to sternal notch. Um, just wanted to make our job as easy as possible once we're ready to intubate. Post-intubation meds ready. This is something we're going to go over in not the next slide, but the slide after that. So I'll wait for that. When we do place our advanced airway, remember that we're going to do capno. Again, sorry to hit on it so many times, but very, very important. But we also need to go through our other metrics, the or other physical findings, absence of sounds over the epigastrum. We have good lung sounds. There's maybe misting in the tube, good chest rise and fall. Once we know it's correct, we'll secure it and we'll monitor and route and keep on repeating our assessment in case there was maybe a bump or when you remove the patient, the tube got knocked loose. If we're uncertain, um, let's look, make sure that the tube got through the vocal cords, go take another look, and then obviously we're going to use our other exam findings. We did not place the tube correctly. We're going to remove it, obviously. Do not leave it in if it's a bad tube. Make sure we ventilate and we can attempt again or continue BVM ventilations. But remember, if we're going to do another intubation attempt, we're going to pre-oxygenate these patients again. All right. Blue 5, this is our pain control and sedation protocol. Um, Pain, this is more like maybe we have some grimacing. The patient is sweating. You can see tears coming from their eyes after an intubation. We're going to want to medicate with fentanyl. This is to make the patient more comfortable. I think sometimes in the heat of the moment, if we do get ROSC, it's maybe not the top thing on our mind um, to check for this, but very, very important. The patient can still feel things, um, so making sure we're controlling their pain if maybe the signs are worse than just a little tearing, they're opening their eyes, you can hear some like forceful coughing, um, they're trying to self-extubate, they're tachycardic and hypertensive, and that's new or it's getting worse. You can tell that the patient is not sedated properly. That's where we're going to move to our midazolam or ketamine. Um, Remember, stick to one. The patient can't be hypotensive. Both of these medications can cause hypotension, and that could hurt the patient more than it could help. Um, Between choosing midazolam and ketamine, that's provider choice. In my opinion, if I have a patient who I'm worried about self-extubating, they're very uncomfortable with the tube place, midazolam is going to get set up a lot quicker than ketamine. But some people are very quick at doing the math and setting this up. So provide a preference on whether you want to use midazolam or ketamine. Just please do not use both at the same time. Surgical crike. This is our last protocol. We're just gonna run through real quick. Remember, we're gonna grab our thyroid cartilage with our non-dominant hand, and we're gonna find the landmarks that we want. If you start from kind of the bottom and work your way up, you're gonna feel a little bump and then the big bump. You want to be in between those two bumps for your cricothyroid membrane. Once you find your right spot, you're going to make a vertical incision over it, 3 to 5 centimeters. Remember, want it to be vertical rather than horizontal because there's a lot of vasculature that runs on the sides here um, that can cause some pretty severe bleeding. It's going to obstruct your view and be detrimental to the patient. Remember that this vertical incision can still cause bleeding, so having suction ready to go is going to be um, really key for your success. So once you make that incision, um, whether you have the Trousseau's dilators or you're gonna use kind of a trach hook, um, what do you have? You're gonna widen that incision and puncture the membrane. And then once you puncture through the membrane, you're gonna place your tube, and then we're going to confirm it's in the right place. Again, with lung sounds, absence of sounds in the epigastrium, and end-tidal CO2. So that is our surgical crike procedure. Quiz, remember, lots of select multiple questions. That is my fair warning to you. So please read carefully, but need a 70 to pass. And that's it. Thank you very much for listening, and I hope you enjoyed.